I'm pleased and honored to introduce today's speaker, Professor Claudio Lamartina. Professor Claudio Lamartina is a highly experienced spine surgeon. He's Chief of Department Istituto Ortopedico Galea di Milano. He's Professor of Orthopedic Specialization School at the Milan University, Professor of Neurosurgery Specialization School at the Turin University, Deputy Editor, European Spine Journal. He's the author of over 100 scientific publications, performed more than 100 complex vertebral surgery a year on average in Italy and abroad, and has a personal experience of over 3,000 complex spine surgery, including sublaminar bend techniques. Today, he's going to share his large experience on sublaminar bend techniques and outcomes, and how he sees the big potential behind this solution. Before I hand the mic over to Professor Lamartina, I have a few housekeeping items to cover about this presentation. First, today's webinar will be available on demand after the live session and will be shared to all the attendees. Next, we'd love to hear from you during today's presentation. If you have a question for our speaker, feel free to send it through the chat platform. We'll be answering questions at the end of the session. So without any further ado, I'd like to kick things off by welcoming Professor Lamartina. Professor, over to you.
Thank you very much, George, for giving me the opportunity to share with you my experience with the sublaminar band, or invite me in this very interesting webinar. This is my team in Istituto Ortopedico Galeazzi in Milano, Italy. This is the new Galeazzi, ready more or less at the beginning of 2023. My topic today is the power of sublaminar bands in spinal surgery. Few seconds for my disclosure information. After this, we can start. This is a very good paper, a systematic review in which you can read probably the best paper in this topic. The result of this systematic review is very interesting, but basically this review confirms that sublaminar bands are a very good way in order to treat adolescent idiopathic scoliosis, or in general speaking, deformity. Deformity in which you can, in very intuitive way, reduce the angle, as suggested by Mazda many years ago. It's really intuitive. There is no significant problem in this kind of surgery. You can achieve a very good result, like you can see here, in moderate deformity, as you can see in this example, in stiff curve, in which you can see a good result, even if there is a deformation of both rods in scoliosis. Just in order to try to avoid this kind of problem, that means the deformation of the concave rod, but very often also the convex rod in scoliosis, you can follow this very simple tips. You have to connect the two rods before performing the reduction with a very simple cross-link. In this way, you reinforce significantly the stiffness of the rods without increasing the diameter. As you can see in this example, is more or less the same kind of deformity, the same kind of scoliosis, in which because we use before the reduction this very simple cross-link, we have less the formation in scoliosis of the rods. But the point is, the question is, this kind of surgical technique can help us in a very complex deformity. In other words, how the power of sublaminar band. I think the best is to give you this example. For instance, this is an adult idiopathic scoliosis with a severe curve, thoracic curve, more than 120 degrees. This is a very stiff curve, as you can see in bending. You can see also a severe deformation of the chest. In fact, you can see very well the hump. As you can see, it's very shaped hump. There is also a huge asymmetry in the trunk. If you consider this half is totally differently in the other, but this is a really a very severe deformity. This deformity can be treated by a sublaminar band. The answer is yes. Look at this example. We perform a T4L3 fusion with multiple ponte osteotomies, sublaminar bands, of course, and 3 rods technique. Let me show you the surgical field. Basically, we put one screw here in the concavity, a second screw here, once again in the concavity. We first reduce the apex of the deformity with 5 sublaminar band, as you can see at that level, that level, that level, and that level. In this way, we significantly reduce the apex of the deformity, but we complete the correction, implanting one long rod in the concave side, as you can see here, but also one more convex rod, using this rod like a long lever arm. Doing this at the end, you can achieve a very nice reduction of this extremely severe deformity. As you can see here, you can better see the amount of the correction if you look at the deformity before and after the surgery. As you can see, the trunk is much better. The symmetry of the trunk is significantly improved. There is no significant malalignment imbalance of the shoulder. Also in lateral plane, the reduction is very nice. Actually, this is a very old technique. In fact, Mosher in the early 70s described this, the sublaminar wires together with the Harrington rod. A few years later, Luque developed a more flexible rod with, once again, the sublaminar wires, introducing what is a very well-known technique, the Luque technique. Here you can see an example. Basically, this kind of technique is especially useful in case of neurological scoliosis, as you can see in this example. But there is no doubt sublaminar wire has a significant problem. the idea to use the band instead of the wire for correcting the scoliosis was proposed by Mazda. Actually, this is a very good technique also in terms of reduction of the fibrosis around the bands. In fact, using the sublaminar band in this model, the amount of fibrosis is very low. It is very important because one of the main problems of the sublaminar wire was the problem correlated to the risk to create dura tear when you have to remove the wire. With this technique, there is no this problem. But I want to focus not only the power of this technique in correcting the coba angle, but also in three key points that remain a challenge for the surgeon that want to treat scoliosis or in general coronal deformity. The first key point is the rotation. Here you can see how this kind of technology can significantly reduce the rotation at the apex of the curve. But I want to show you an example. This is a case of infantile idiopathic scoliosis, in which you can see a severe deformity. But what I want to focus is that the amount of rotation at the apex of the curve is close to 90 degrees. In fact, you can see in a P view the apical vertebra like in sagittal plane. That means the rotation at the apex is close to 90 degree. And this is there is no doubt a challenge for the surgeon. Once again, we perform the technique of sublaminar bands. In this case, we always add also multiple ponte osteotomies. Here you can see the result. The result is very, very nice, not only in terms of correction of the coba angle. This correction is huge, there is no discussion, or the correction of the sagittal malalignment. But what I want to focus is that we significantly reduce the apical rotation of the curve of the vertebra. Here you can see before and after the surgery, you can see very well the clinical result. The second key point is how we can increase thoracic kyphosis in case of lordoscoliosis. Once again, this is a very complex topic. I want to show you one example. This is a case of lordoscoliosis. As you can see, this subject has a global lordosis in thoracolumbar area with a kyphosis, a compensating kyphosis in cervical spine. The lordosis in thoracic spine is 20 degrees. Here you can see very well the hump, the asymmetry of the patient before surgery. We decided to fuse from T3 to L1 using once again the same technique, the 3 rods technique, with a small short rod in concave side, plus 2 long rods, one in concave, the other in convex side. As you can see, there is a good coronal correction. But what I want to focus now is the amount of kyphosis that we achieved after the surgery. Here you can see that before surgery, in the thoracic area, there was a lordosis of 20 degrees. After the surgery, a kyphosis of 20 degrees. This is really, really important for the mechanics of the chest. You can see very well also that the sagittal profile is much better than before the surgery. Here you can see also 1 year follow-up in which the result is stable. And you can see also that the amount of kyphosis in cervical area is significantly reduced. The last key point is how to preserve lumbar lordosis. In fact, as you know, when we have to treat lumbar scoliosis, there is a significant risk to reduce the amount of lordosis. We have to reduce the Cobb angle without reducing the amount of lordosis, so preserving the lordosis. How we can achieve this kind of result? One example is a case of Lenke 6, in which the main curve is in the lumbar area. The strategy is that you have to start with the convexity in lumbar area. Doing this, you can preserve the lordosis, as you can see, comparing the lordosis before and after the surgery. The lumbar lordosis remain more or less the same. If you pay attention about this point, the strategy in this kind of lumbar scoliosis is different than in thoracic. It's just the opposite. You have to start with the convex side. And doing this, you can derotate the scoliosis. You can reduce the angle without reducing the lordosis. And this is a very important, obviously. Here you can see the result of this kind of surgery. But the power of sublaminar band is not only in this case, in case of severe scoliosis, or in case you have a lordoscoliosis, but also in congenital scoliosis, for instance. You can use this kind of technology, achieving a very good result, as you can see in this example, in which sublaminar bands plus multiple ponte osteotomy can give you the chance to achieve a very nice result, as you can see here. But not only in congenital scoliosis, but also in syndromic scoliosis, as you can see in this severe deformity, in which you can achieve a very nice correction in both plane, in coronal and in sagittal plane. But also in case of Marfan, once again a syndromic scoliosis, in which there is a very stiff thoracic curve, in which you can achieve a good result, even if the stiffness is so relevant, like in this example. One more example, in case of Down syndrome, this is an extreme stiff curve, more than 120 degrees. Once again, you can see the result of the surgery. Mainly, you have to see the difference between before and after the surgery, especially in clinical picture. And finally, the last example. One example of kyphosis is a post-surgical kyphosis because of the multi-level laminotomy that the neurosurgeon performed because of syringomyelia, Chiari syndrome, multiple arachnoid cysts. At the end, the patient developed a severe kyphosis in the lower part of thoracic spine, This was painful, but also this was the cause of myelopathy at that level because of the compression. In this case, you can follow a very interesting strategy in order to reduce the risk of pull out of the distal screw in this kind of construct. As you can see in this in this study, you can see that you have a screw and sublaminar band at the same level. Doing this, the risk of pullout is significantly less. What we did in this example, in which you can see in the top, we combine different tools like hooks, like sublaminar band, just in order to create a not so stiff, not so rigid construct in the top in order to reduce the risk of PJK. But what I want to focus in this specific case is that the fact that in the same lamina, as you can see here, we put screw and sublaminar band. Doing this, the risk of pullout is very, very low. We did this bilaterally, as you can see very well here. It is a very simple way in order to reinforce the distal part of your instrumentation, in which you can significantly reduce the risk of pullout or distal failure. Here you can compare before and after the surgery with a very nice correction. At the end, the thoracic kyphosis is normal. The patient was very happy for this. She was totally pain-free. The compression of the cord was solved. In conclusion, we do believe that sublaminar bands are a very good technique, not only for treating moderate deformity, but also in case of severe deformity in pediatric or adult patients, and not only in deformity in coronal plane, but also in sagittal plane. Thank you very much for your attention.
Thanks a lot, Professor Lamartina, for this nice presentation. We do have a couple of questions for you from the attendees.
Yes, please.
The first one is specifically, how do you manage the burn and compression, especially on the hyperlordotic lumbar spine? And if you have any technical recommendation.
In case of hyperlordosis thoracic?
Lumbar spine, yeah, lumbar spine.
The problem is exactly the opposite. When you try to treat a scoliosis in lumbar spine, the problem is that you reduce the angle, and at the same time you reduce the amount of lordosis. That means if you have hyperlordosis in lumbar spine, you can use this kind of technology, but in this case, you have to start in concave side and then in convex side. When you want to preserve a lumbar lordosis, you have to start just in the opposite. You have to start with the convex side.
Okay, thank you. We have another question, which is, and I think you mentioned this with some tests on rabbit, I think. Are you concerned or have ever experienced epidural fibrosis because of the sublaminar band?
Are you asking me in case of neurofibromatosis, correct?
No, sorry. The question is, are you concerned about epidural fibrosis because of the sublaminar band?
This is a very strong point in favor of sublaminar band. Maybe you know that if you have to remove sublaminar wire in case of a Luque technique or Harrington-Luque technique, there is a significant risk to lacerate the dura during the maneuver for removing the sublaminar wire, because when you cut the sublaminar wire, you create a very sharp end of the end of the wire, and when you remove this wire, there is a very high risk to lacerate the dura. Vice versa, with this band, there is close to zero fibrosis. That means in case of need to remove the sublaminar band, you can do this without any problem. You can remove because the amount of fibrosis is very low. And this is very well demonstrated in the study that I presented in my presentation.
Yeah, I saw that as well. Thank you. Another question for you is about, I think, PGK. What would you be your recommendation for using the band, especially on a tethering construct for the purpose of the PGK prevention?
PGK is a nightmare. That means it's really a big problem. There is no only one way in order to reduce the risk of PGK. In general speaking, one of the best way in order to reduce the risk of PJK is to restore a good sagittal alignment. But sometimes this is not enough, especially in elderly, because you have to pay attention also about your surgery. If you cut or if you reduce the stiffness of the posterior elements, especially in spinous ligament, the risk of PJK is significantly high. Also, there is an extra risk if your construct is stiff, because if the upper part of your instrumentation, but this is true also for the risk of DJK. Anyway, if the upper part of your instrumentation is very stiff, the risk create a critical border between the normal spine and the instrumented spine is high. This is one extra reason for having a PJK. That means we should to pay attention about different point. If you want to reduce the stiffness of your implant, you can follow different strategy. One is, for instance, implant rods with different diameter. Or better, if you reduce the stiffness of your construct, reducing the number of screw in the top. You can combine screw and hooks, or hooks and the sublaminar band, or screw and the sublaminar band. Combine this, you significantly reduce the stiffness in the top. This, in my opinion, is probably the best way in order to reduce the risk of PJK.
Okay, thank you. Another, I think, a general question about the band, using the band. What mostly drives your decision to use the band instead of a screw?
So, sorry, the quality of the audio is not perfect. Can you repeat the question?
The question is, what mostly drives your decision to use the band instead of a screw?
Oh, okay. If you are asking me, in the top of the construct, I reduce the number. I avoid to end with 2 screw, but I prefer to end the construct in the upper part with 2 hooks or 2 bands. I prefer bands because bands are more mechanically better than hooks. The band adapt itself to the laminate. Vice versa, the hooks is a metallic material. That means if the hook is not exactly parallel to the lamina, there is an asymmetrical stress on the bone. For definition, in every case, when you put bands at the end, the bands adapt itself to the lamina. In this way, you reduce the stress between band and the bone. This is a very important. The other very important point is if you implant screw, for instance, the concavity of the curve, you put screw in a very thin pedicle. Sometimes it's impossible to put a screw inside the pedicle. You will put a screw following the technique that we call in-out-in. But doing the grip of the screw at that level is significantly less. It means create stress of reduction. The risk of blowout is very high. Totally different is if you use the bands, because modulate the amount of correction. You don't have to engage the lip in the rod. You can achieve a partial reduction if a complete reduction is impossible. But I showed you how to solve this kind of problem using the 3-rod technique, in which you divide the stress of correction in 2-3 different steps. And doing this, the risk of failure is significantly less. At the end of the day, the amount of cob angle correction, the amount of the rotation is significantly high. Also, in case of a curve more than 120 degrees, as I showed you before.
I think that's all we got in terms of questions. Thanks for your detailed answers. If we don't hesitate to contact us. We will be sure to follow up afterward. Again, many thanks, Professor Lamartina, for your time and this very nice presentation.
Thank you. Thank you very much.
Thank you all for your attendance. As soon as we post the record, we'd like you to encourage to share today's webinar with your preferred social networks. And I wish you a great day. I'm looking forward to see you at our next InPlanet webinar. Thank you.
Thank you. Thank you very much. See you soon.
Thank you.